Right, so welcome everybody to our all CMT type virtual break room. My name is Mario Saporta. I'm a physician scientist at the University of Miami, where I lead our CMT Center of Excellence, and also we work with both basic translational research in CMT and also clinical trials now that some treatments are in the clinical trial stage.
Hi everyone, my name's Robert Pryor. I'm a PhD in neuroscience. I work on Charcot-Marie-Tooth disease in several different forms. I'm currently based in Bonn University looking at developing drug screening platforms for the disease. And I've also played a role in launching a company from my former lab called Augustine Therapeutics. And so the focus of this is to answer any of your questions on all forms of CMT, and I think we already have one question in the chat.
Neuropathy, multiple neurological tests, diagnosed with CMT last year. We have a genetic testing done shortly, chemical engineer for 51 years. And then he's asking about environmental factors and if that could have contributed to his neuropathy or her neuropathy. So yes, until you have a genetic diagnosis of CMT, there's always other potential explanations for neuropathy. So neuropathies are basically the term that we use for any disease that causes nerve damage. And CMT is one of kind of the big groups within neuropathies, but there are other types. Diabetic neuropathy is a kind of a very common and known form of neuropathy. Neuropathies from chemotherapy agents or other drugs as well. But then there is this group of what we call toxic neuropathies that can be caused by environmental exposure to certain chemicals. So it's not every chemical that will cause neuropathy. It can cause a host of other issues with your lungs, with your kidneys, with your blood cells. But there are certain chemicals that can cause neuropathy. So yes, if you have a history of exposure to those particular chemicals, there's a chance that they could be the sole cause of your neuropathy, or they could have made your CMT worse. Because we know that if you accumulate other causes of injury to your peripheral nerves, having CMT, this will make your CMT worse because you're kind of adding up different injuries to your nerves. And that's true, for instance, if a patient has CMT1A and diabetes, or if a patient has CMT and is exposed to chemotherapy agents, the neuropathy would tend to be worse than it would otherwise be. So the short answer now is yes, it could be that chemicals could have contributed, but it's important to know what type of chemicals you're exposed to, for how long, and if they have potential to be neurotoxic.
Yeah, they're generally broken down into two major categories: inherited peripheral neuropathies, which CMT falls into, and all genetic forms, and then the acquired peripheral neuropathies, where diabetic and toxic induced peripheral neuropathies, and alcohol can also can cause neuropathy. One new message. Do you have an easily understood way to describe the relationship between different types? For example, types of CMT that are the same in family, type 1 and type 2. Hold on, I'm just going to wait. So, oh, there's more questions. Okay.
Well, let's take first the question about CMT types, because I think that's a very important kind of way to start talking about CMT. Where Robert's pulling up like a schematic that we will use to try to answer this question more kind of visually. The major distinction that we make initially on the different types of CMT is based on what part of your peripheral nerve is mainly affected by your genetics, your neuropathy. So if you think about a peripheral nerve as an electrical wire, where you have the inner part, which is kind of the metal part where the electricity is running through, and then the insulation, which is that rubbery part that's kind of making it more efficient, that transmission. Our peripheral nerves are kind of the same way. The inner part we call the axon, which is the terminal part of a nerve cell. And then you have the insulation, which is called the myelin sheath. And main function is to support that axon so that the axon is healthy, but also to make the transmission faster. If your genetic mutation or change is causing problems with your myelin sheath or the insulation of your nerve, we call this CMT type 1. And if the major problem is actually happening in the inner part of your nerve, the axon, we call that like donor CMT or type 2 CMT. So that the major distinction, and that comes from the fact that, as you see on this figure here, the type of CMT or it's really linked to specific genes. So certain genes will cause more likely type 1, and other types will cause more likely type 2. There's some overlap there, but in kind of in most senses that this kind of remains true. And usually, there are very, very, very rare exceptions, but usually the type of CMT that runs in the family is the same. So if you have 3 generations of family members affected in a single family, the most likely scenario is that all the 3 generations will have the same CMT type. So if it's type 1 or type 1A or type 1B, that will be the whole family. If you have type 2A, 2E, that will be the whole family will have the same. There are very unusual cases where a single patient could theoretically get different types of CMT from different branches of the family, but that's very, very unusual. So in all kind of sense, that it's likely that the same mutation will be found in all family members, irrespective if they even show a little bit of differences in their severity, age of onset, or features of their neuropathy.
Okay, the second one is from Lynn. I'm a 65-year-old woman who has had a slow, gradual loss of function in the hands, legs, and overall body sensation. Since COVID, I've had a rapid decline in function, and my nerve function has increased or decreased, I assume, dramatically, making life very challenging. Any thoughts on slowing the decline? That's very difficult yeah, I would say more so to look after yourself and improve the things you can control, like your health, your fitness. But I don't know if you would want to
Sure. So there are 2 things that we have to think about. So I'm not sure when you say since COVID was just the period of COVID where everybody was locked up at their homes, and a lot of my patients, if not all of them, with CMT and other neuromuscular conditions have experienced that deterioration during that period of time where they couldn't even walk outside their homes. So the lack of exercise or physical activity have made symptoms progress faster. We're seeing this reversing as patients are going back to normal life and being able to socialize, exercise. So it's very important to not really give up on working on your function and health. If it's because you had COVID, then there's this whole issue of long-term COVID or chronic COVID, which we still don't understand fully, but it seems like in certain people, COVID kind of lingers and still causes problem way after healing from the infection. So it's very important to connect with your physician as well to just check if anything changed on your CMT exam, even on the nerve conduction, maybe to explain why you have deteriorated, if that's more than would be expected from just the lack of physical activity, the kind of sedentary life that we lived for over 2 years of the pandemic.
Okay, we have another question. I've CMT type 2 that was not diagnosed till I was 62. I am 70 now. I am also type 1 diabetic that was masking my diagnosis, dealing with pain and muscle wasting in the legs, arms, and hands, along with double vision and hearing issues. So far, genetic testing has not found any subtype of 2. I am the only one in my family that is known to is known so far. How can I be the only one to have this?
Yeah. So there are two questions there as well. So the first one is the fact that you have type 1 diabetes does increase your risk of having neuropathy, and most diabetic neuropathies are essentially axonal neuropathies. So they look like type 2. So it's very important to make sure that you indeed have CMT as well, or if your neuropathy is due to diabetes. And there are ways to figure that out. The fact that you are the only member of your family with CMT is not unheard of. So we understand this from just thinking about how our DNA is copied and replicated in our cells. It's a process that's not fail-proof. So every time that happens, there can be what we call mutations or errors in how the copy is made. And if that happens very early in life, meaning when you are a couple of cells, you can develop a disease causing mutation that was not technically inherited from your parents. And that's what we call de novo or a new form of CMT. So having you being the only family member with CMT does not really exclude the diagnosis of CMT, and it's not that uncommon. So in certain types of CMT, 20 to 30% of patients are what we will call de novo. But it's very important to try to figure out what the genetics of your type would be, because that's the only way to be sure that what you have is indeed CMT type 2 on top of your type 1 diabetes, or whether your neuropathy is only associated with type 1.
Second question from Shelley. How does the MPZ gene present in the myelin and axonal CMT? I was diagnosed with MPZ gene, but was not told the type.
Mm-hmm. So MPZ has this kind of weird characteristics, which depending on the mutation you have, you can either have a kind of early onset demyelinating type of neuropathy or a later onset, more axonal looking CMT subtype. So it's one of the few genes that where you see that kind of being present in both lists of CMT1 as CMT1B or CMT2, and it can be 2H or 2J. But it's the same gene, but again, depending on where in the gene, which corresponds to where in the protein NPZ the mutation or the change is, the way you present is going to be different. So if you have a very early kind of onset of diagnosis and your nerve conduction shows that your conduction velocity is low, you have CMT1B. If you had a later onset and your nerve conductions are not that slow, then you would be classified as 2H or 2J, so the axonal form of MPZ. This may have implications kind of further down the road when we talk about treatments, because it's possible that there are different mechanisms involved in the way those two kind of different presentations of MPZ, CMT happen. So it's important to at least know where you are, because that may tell you where things are in terms of research and treatment development.
Okay. The second question is from me, if you were still affiliated. If the preclinical development for the possible CMT2A, H66 drug and Augustine Therapeutics goes well, do you have a ballpark guess for when this might be available in clinical trials? Would it likely involve locations in the US also? Yeah, it's going to take a while. It's a slower process than, and CMT2A is not the first subtype of CMT that will be validated in. It will first be validated in CMT type 1A, actually, and in chemotherapy-induced peripheral neuropathies. Those two are going to go for ahead together. And for how long it would likely involve and US locations, would you have any idea about?
I don't have any privileged information, but just because for 2A, it being such a rare form, even if it's the most common type 2 type, it's still fairly rare. So to be able to recruit enough patients in a clinical trial, it's very likely that the trial would have to be a multi-center international trial with centers probably in Europe, in the US, and maybe in other centers even, to be able to collect enough recruit enough patients. So that's kind of my my impression, because even for 1A, some of the trials are international, or actually the two trials that we had, one that it's done and the other one that's kind of finishing, they were both multi-center trials across different continents. So for rare disease, it's very important to have a large kind of network of centers, for sure.
Okay. EMG studies determined that I was CMT2.
And that's for the patient with type 1 diabetes?
Yes.
Yeah, because
Richard,
the problem is that the EMG is not diagnostic of CMT. So we
Mm.
cannot tell with 100% certainty, though we can suspect very strongly that a patient has CMT based on the EMG. So I'll be careful on saying that the EMG told you that you had CMT2, because what the EMG told you is that you have an axonal neuropathy. And again, many neuropathies can be axonal, including CMT2. But diabetic neuropathy, most toxic neuropathies, certain infectious neuropathies, they're all going to cause axonal findings on the EMG. So that kind of yeah.
And then the second one was in response to Sarah's earlier message. I have CMT2N at 55 years. I'm not pre-diabetic. Going to a nurse on Monday about a diet.
Mm-hmm.
What do I need to tell her, as she has no idea about CMT? Thanks.
Yeah, so it's very important to make sure that they understand that, and I mean, the nutritionists and nurses, they will be careful about that, but you have to be very careful not to become deficient of certain vitamins specifically. They're very important for nerve health. So just making sure that they understand that you have CMT, that CMT is a neuropathy, and that you have to really work hard not to accumulate other issues that could make your neuropathy worse. And the big ones are diabetes, vitamin B deficiency, B12, B1, and the thyroid, so hypothyroidism. So making sure that you have those things monitored, and that they don't really go too aggressively with the diet. I think it's very important. And also to make sure that you actually have on your diet good sources of those vitamins and all the elements that are important for a healthy diet. So good amount of protein, low amount of carbohydrate, especially processed food, and a good source of fat as well, healthy fat, because that's important for your myelin as well. So I think just having a good, just
well-balanced
diet.
Well, hi, I got CMT type 1A and wondered if you know of any drugs or supplements which may help in reducing or removing the excessive PMP22 produced in the myelin sheath. Well, that's kind of, yeah, what all researchers are trying to investigate. There are clinical trials for the Pharnex for 3 drugs that are currently on the market. Yeah, but I can't really comment on what supplement would reduce.
Yeah, so I mean, we don't know yet. So that the whole purpose of having clinical trials is to make sure that we find something that not only works to some degree, but that's safe as well. And that balance is always kind of what we're trying to accomplish. So there's nothing right now that I would prescribe a patient, either medication or supplements, that I am convinced that's going to be helpful and wouldn't have risks of toxicity. So every medication that you pick up in a pharmacy have side effects, and our job is to make sure that the exposure to that side effects makes sense from the potential benefit you can get out of a treatment. And so far, we don't have that medication or supplement where we feel that this will be the case. So for now, it's way more important to have a healthy diet and keep yourself physically active than taking any drug or supplement until we have better evidence that this will be helpful.
Question from Nick. Given the pharmaceutical advancements being made around 1A, is there any commonality or connection those advancements may apply to type 2 or specifically type 2T. Some of the advancements look at targeting common mechanisms in the disease, such as axonal degeneration, loss, or survival. Others are more gene therapies, and you could split the gene therapy into sort of two packages: the delivery method and the method of reducing the gene expression. So successes in the delivery will be taken over to other forms of CMT, and then successes in targeting more common pathways that may be applied to all forms of CMT, such as there's two companies, Augustine and Horizon, targeting H6 inhibitors, which target the axonal part of the disease. So
Yeah, and the other thing is like every advancement within a group of diseases will create tools and ways to an experience to help other types as well. So I know it's very kind of frustrating if you don't have 1A to feel like you are kind of left behind, but everything that we're learning from 1A, even if the treatment itself will not be applicable to other types of CMT, will give us a lot of understanding on how to conduct clinical trials and also develop tools that, if modified, can maybe be applicable to those other types. So hang in there. We will have something, but we just have to follow this path, which is the path of least resistance, going for 1A first and then moving forward to other types.
And Sarah just responded, "Thanks, God help me, I'm vegetarian."
Be very careful with your B12 because my brother is vegetarian, and I remember having to give him B12 shots now and then because his B12 was running low. Yeah, so be very careful because I mean it's a healthy diet, but it can cause certain deficiencies that you don't have the luxury to have because it will make your CMT worse.
Yeah, Richard Macbeth. I also have high arches and hammer toes, foot drop in both legs, and I have to wear AFOs. Dr. Saporta, were you involved in the designation of your group as CMT Center for Excellence? If yes, can you speak on the process? Also, what would you tell a patient about what the center means versus the average local healthcare institution that does not have that designation?
Yeah. So the CMT Center of Excellence designation is actually granted to us from patient foundations. So patient foundations that have looked into different centers, they are expecting to see certain things offered on that center and certain expertises to be present that will kind of give you that designation. So to be a center of excellence, you have to have at the least a knowledgeable neurologist within the CMT field, and also have what we call multidisciplinary care team. So usually that will include a genetic counselor, a physical therapist, or an occupational therapist, social worker. Sometimes they'll have people that are more focused on respiratory evaluations, swallowing, depending on, again, the subtype of CMT that you have. But at the minimum, you would expect that center to have a genetic counselor to help patients and families understand how to navigate the genetic diagnosis of CMT, and also a team that would then plan how to manage the CMT. Because as we are waiting for those treatments, there's still a lot of things that we can do to minimize the impact of CMT in one's life and to make sure that they have their best and healthier life. And then that's really accomplished, I think, with this team. So the main difference of going to a CMT center and just your local healthcare is that you're gonna have a conversation with somebody that have seen probably hundreds of patients with CMT, and having taken care of them, and also other specialists that will help you navigate your symptoms and again manage your disease. Yeah.
I am 81 and I started seeing changes at 65. What are my chances of getting help at my age? I believe I have type 1A. I cannot walk without the aid of a walker.
So that's, I mean, the first thing is to make sure that you have 1A, just to understand what's going out there. There's a trial that's finishing that may provide at least some form of stabilization for your disease. There's another trial coming on probably next year or very soon. So really knowing your type is very important so that you can really understand what's out there or what's coming. But unfortunately, with how CMT is currently in terms of what we can do to stop the progression or reverse symptoms, we're still unfortunately not there. The most important thing, as I mentioned before, and I always kind of emphasize that, and that will come back on the next question, is that it's very important to keep yourself active, because this is a disease where if you don't use your muscles are just going to give out, because they need that kind of constant stimulation of whatever nerve fibers you have, that connection present. So it's difficult. And of course, as we age, it becomes even more difficult. So I understand how difficult it is to have to use a walker to walk. But that's really what we can do, is really focusing on keeping you active as possible and as safe as possible as well. So the walker may, of course, sound like a horrible thing, but as long as you're safe and you're not falling, it's doing its job, and that's also preventing things from getting worse.
And then the next question revolves around exercise. What is your opinion on strength exercises or physical therapy? I do a lot of walking, but after strenuous exercise, I can barely walk for 2 days. I would chip in on this. I'm also a CMT X-linked type 1 patient, and I always advocate for strength training exercises, keeping active, but I would say avoid extreme exercise, because it can cause more issues in terms of inflammation. So you want to push yourself, but you don't want to kill yourself in the process of trying to build what you can.
Well, the word there is strenuous. So strenuous is not a good word for CMT. You have to find that sweet spot of not doing too little that's not going to be beneficial, but not going past the limit of your body, because the body will let you know that it's not happy with what you did, with you not being able to walk for 2 days. So that's probably a sign that you have to just dial down, reduce the intensity a little bit, reduce the repetition, maybe reduce the duration of the exercise until you find that spot where you feel you got a good exercise from out of it, but you're not feeling miserable for 2 days or more. Anything in the water tends to be a little easier in the body in terms of impact and the potential of hurting yourself. But even if you go to a gym, just make sure that you're doing the right amount of exercise and not overdoing it.
And I would also advocate for stretching. That's very important. Sarah, again, I'm recently taking a fungal medicine every day for 3 months. My GP told me that it takes to take it at my feet, as the fungal infection that does not go away with creams. It's dangerous for my liver, I see from reading. I swim in the sea most days and keep hard to keep my feet dry. Are fungal drugs safe for CMT? There is a publication on toxic medications associated with CMT, which you can. Do you remember the name of the review? It's in the Peripheral Nerve Society or
the foundation website.
Yeah.
That the CMT
Yeah,
Association
they will have
a nice booklet with the different drugs related to how high the risk is. So for fungal medications, they are definitely not in the very high risk. You have to check what exactly, because there are many different fungal drugs, but if they would be in the list, they could be in the very moderate to mild risk. So to take a look at the list to see the specific drug that you're taking, if it's in the list, and then talk to your doctor about if there are other options that might not be on the list that could also treat your fungal infection, because at the end of the day is a risk-benefit calculation. So if the indication of benefit is really there and you need to treat it because otherwise there'll be a high risk of problems, then the toxicity, if it's a small risk of toxicity, kind of makes sense. But if the other way around, the benefit is very small or the risk is too high, that may not be a good way to go about your treatment.
This kind of feeds into the next question, which was, what are your thoughts on the new literature review study from the CMTA that states that the majority of the neurotoxic list is now not neurotoxic?
Yeah.
I think that more comes from experience from patients reporting adverse events on.
So yeah, exactly. So the way this list was originally designed or originally established was just looking to side effect of drugs, and any drug that would list neuropathy as a side effect, it will go into the list. But our understanding is that there are a lot of drugs that would fit that bill, but that the risk is so small that it doesn't make sense to be on the list. So I think that was kind of one of the reasons that this was reviewed, is because at some point patients were afraid of taking any medication, because from a side effect perspective, is like reading the label of the drug. You're not going to take anything because there are a bunch of side effects in there. But what's the real risk for a patient? I think that kind of calculation was made to make sure that people having access to required treatments without having to go to the stress of worrying about, this is in the list of the CMTA. And again, if you look at the high risk drugs, that has not changed. It's really the moderate or mild risk that was probably revealed a little bit to take out everything that's really kind of negligible risk for patients.
The next one's a bit difficult. My neurologist like to repeat nerve conduction testing even after diagnosis. Is this recommended? Has there been any research about the safety of nerve conduction testing on CMT nerves, especially with responses that aren't detectable, but technicians keep trying? I felt it made my CMT worse when I had 2 tests within 1 year.
Yeah, so nerve conductions are safe in terms that they really don't have a lasting effect in your peripheral nerves. So once you're done with the stimulation, you're done. I personally don't repeat nerve conduction on every visit of my CMT patients. Sometimes if they already had a recent EMG done elsewhere, we don't even do one ourselves. We just move to genetic testing and go from there. And then now and then, every few years, we may want to check how things are. But if you already have no responses, I don't know why they would be keeping doing that to you. I think that's not reasonable, because once you hit that floor, and that's why we don't use nerve conductions as much as a kind of progression monitoring tool, is that because once you hit that no response phase, things are not going to change after that. So unless we have a treatment and we're hoping to see things coming back, there's really no point on repeating things like that. So I'm not sure if I can really put your perception of worsening after the EMGs on the EMGs themselves. I don't think that that's very likely. But I would just tell your doctor not send it for nerve conduction study, especially if in nerves that they know they're not going to find responses.
Another question from Vanessa. My daughter, 7 years old, was diagnosed with a genetic sequence mutation in the dynin 1H1 gene, and we've been told it could be CMT2O or SMA-led. I see from the chart that this gene is within the hereditary motor neuropathy category, but I thought type 2 was axonal. Does this mean it's not an axonal issue for her?
Yeah, so I know that this can be very confusing. So distal HMN or distal hereditary motor neuropathy is okay. We can use this slide here. So from a genetic perspective, it's kind of the same condition. This designation is more of a clinical assessment, whether what we're finding in the neurological exam points to both sensory or sensation problems and also weakness or motor problems, or if there's a predominance of more motor or more sensory. So the CMT designation has been historically used for when problems affect both sensory and motor. And then clinicians came up with the distal HMN's classification when they couldn't find any sensation issues with the patient, but otherwise the patient would look like a patient with CMT. Most, if not all, HMN types are axonal as well. So if you look at, the problem is in the motor axons. So in that regards, the issue is still an axonal issue or a type 2 issue. But the clinical presentation is classified as HMN or hereditary motor neuropathy. We now sometimes, when you're talking about certain genes, we even use CMT2/distal HMN to account for the fact that some genes can present in either way, either as a type 2 CMT with sensory changes or as a purely motor axonal neuropathy. So just it's more of a semantic thing than actually a clinical or biological implication, at least for you. For us, we try to figure out why this happens and what actually modulates things being more motor, more sensory, or both.
So then Michael asks, say one of the patient panelists mentioned that sometimes they get more info from other patients as opposed to providers. From their clinical practice, do you feel that there are certain symptoms that perhaps many of your patients report but are not well understood in CMT patients, maybe fatigue, sweating, bowel bladder problems, or other things? Yeah, and I kind of put up this image to sort of highlight several different areas that can be affected with some of the more rarer mutations or some of the more common or not so common symptoms reported with CMT patients. I would agree with that. Fatigue, sweating are very common in CMT patients, and I've heard of quite a lot of bowel and bladder problems.
But just so to answer that from a clinical practice perspective, there are some symptoms that we recognize more and more, and thanks to a lot from the patient feedback and the patient foundations bringing the patient voice into our clinical practice. So fatigue is the major one, because we physicians don't think about fatigue as much, but now that's something that I always talk to my patients about, and fatigue in CMT is probably a multidimensional problem. So there are many ways that you get fatigue, and they're all present in most CMT types. Sweating, of course, is something that we know about from a peripheral neuropathy symptom profile. Bowel and bladder, I think, is the one that we haven't explored enough. So I've seen some patients, not all, but some patients having issues with digestion or constipation. Of course, it's hard to, if it's not common enough within that patient population, to be sure that it's related to the CMT, because those are problems that can develop for other reasons. But I think there's definitely a need to explore this dimension of CMT that may be something that we're just not as aware of as clinicians.
Nick, with all the discussions of exercise and the comments you made about strength training, will strength training get back any muscle atrophy, or just help with the progression of, or help with preventing the progression of further atrophy? You build what you can and you keep what you can. That's the main message, I would say, because there is always room to improve, and that means other muscles can play a role in stabilizing your posture, your mobility, and it will improve with fatigue. And why I go back to stretching again, stretching improves your balance as well. So, and prevents further tightening of, say, your Achilles tendon. So you can actually elevate your foot a bit more. So you will gain back strength, not always in the affected muscles, but there is always a slight bit of improvement that can be made. So if it's there to be made, take it. Don't let it waste away. That's coming from me.
That's 100% true. And you also have to think about, okay, we are dealing with something that likely will progress, even if it's slowly. The higher you start that progression from, meaning the more fit you are, or the better your muscles are trained, the least you're gonna feel that progression getting to a point where things will affect you too much. But even if you have developed weakness or atrophy, there are always muscles or parts of the muscles that will respond to therapy. And the other way is it's true as well. If you don't do it, it's going to be worse. So I think there's really, from my perspective, it's not really a choice unless you're just kind of not going to do anything about it.
Then Shelley responding that review didn't look at any papers for most of those drugs. I can't comment too much on the review, Shelley.
Yeah, I think just because there's not a lot, like a lot of the data that's derived from, I think you're talking about the
Yeah, they're
neurotoxic,
neurotoxic.
it's coming from data from clinical trials, which it's really the best we can get, but it's nearly not good enough because it's not real life data. And been running clinical trials for a while now, we have to report even if a patient is needs a little bit different. So things that will show on the label may not necessarily reflect the real risk of a drug. But that's kind of where most of the information is compiled in a sense. So
Another question from Sue. My kids were recently diagnosed with CMT, a rare form. Do you have any advice on how to tackle an understanding of a rare form of CMT?
yeah. So I mean, the first thing is connecting with people that can help you in the process because it is daunting when you get that bunch of letters on a paper and you try to understand what that means to your kid. So connecting with other patients, connecting with patient foundations, connecting with people that are knowledgeable about the disease in the clinical setting, I think all are things that will help you. If you have a background in biology, trying to get some of the information out of the internet, everything is there. But if you don't, then I think really recruiting people that will help you understand what that means and what are the things that you should be doing to make sure that your kids are as healthy and happy as possible. I think that's really the most important thing.
And Shelley was just responding. I definitely learn more from the CMT community than from my medical team. Hopeful of that. Will says, I've been on creatine for quite a few months now, and I've seen some massive improvements in my overall strength. It's a really research supplement and used commonly by athletes and other people in the gym, yet I've never heard of a doctor or researcher mention its use. Have you heard of it or recommended to people with CMT? Creatine is one of the most researched drugs for muscle development. So it is a really good supplement to take, and there's been no side effects, negative side effects really with creatine, but I would always take everything with caution, just do recommended doses. Um, I've not heard it being discussed for in the CMT community, but in the general gym community, it's an essential.
Yeah, well, because I mean, the problem is the level of evidence that's required for a prescription of a supplement, especially in the gym environment, is not the same as in the clinic. So I don't personally prescribe it because I don't have the evidence that I should. I always tell my patients, if you want to try, of course, you're free. That's something that you can buy yourself and try. But I would not recommend because my role as a physician is to make that judgment of evidence for benefit, evidence for risk, evidence for cost, and try to come up with what is the main or better recommendation that I can give. And I don't feel I have that for creatine or for any supplement, at least for now. But if you're, again, agreeing with Rob, absolutely, the safety profile seems good enough that you can try, see what you get a very good response. I had a lot of patients that tried the same and didn't get anything out of it. So because I see the two sides of things, I'm a little bit more cautious about recommending it for everybody because I don't think that should be done, at least with the level of evidence that we have right now.
Vanessa, what does genotype specific MRI muscle changes mean? We had an MRI done, but it came back normal and led to the genetic testing.
So there's no genotype-specific MRI change. So the way that MRI changes in CMT is it shows that the muscles that are affected by the neuropathy are going to be smaller than what they would otherwise would be expected to be. And as the disease progresses, that muscle fiber is going to start being replaced by fat or connective tissue or scar tissue, which is a normal process of muscles that are aging or muscles that are disconnecting from their peripheral nerve. Um, Having said that, again, that's a very general way that muscles react, and it's not specific to a genotype. So we cannot give a genetic diagnosis based on MRI. And the MRI is not also, it's a good way to diagnose CMT because the changes may take a while to show up. So if you're going to wait for the MRI to change, to think about CMT, you're going to lose a lot of time. And also, you're not going to be specific enough to make sure that you know even if the patient has type 1 or type 2 CMT. So MRI is being used currently as a research tool and hopefully as a biomarker, maybe in clinical trials to try to capture progression in the short span of a clinical trial, but it's not used for diagnosis. So I'm glad that you had your genetic testing because that's the way to diagnose CMT.
And then Shelley asks, have thyroid issues been linked to CMT at all?
So not linked because CMT is genetic. We know where CMT comes from. It comes from a DNA mutation. But if you have low thyroid can cause a neuropathy by itself. So patients with hypothyroidism can have a hypothyroid neuropathy. And for that reason, we make sure that patients that have CMT have that screening on their annual kind of well-being visits, and if they do have low thyroid, that they are treating it so that they can be at normal levels of thyroid function to prevent further deterioration of the neuropathy.
And then Michael asks, thanks for your answer. Based on your feedback from other patients, do you manage such bowel/bladder problems any differently compared to how you would for a non-CMT patient? Or
not really, because we don't have even neuropathy specific treatments for gastrointestinal or bowel bladder symptoms. So we just basically treat the symptom. We always try to rule out that there's not other causes for the problem because, again, as I mentioned, you can have bowel or bladder problems from a host of different issues that are not CMT related. But if it indeed is the CMT, we'll treat it as a symptom of the neurological condition, as we would do for patients with, for instance, multiple sclerosis or strokes that can develop those symptoms and complications because of the nervous system not being able to work well with your either gastrointestinal or urinary system. So short answer is no, we treat it as a symptom after ruling out that there's nothing else causing it.
And Vanessa asks, how should we be thinking about supplements in pediatric context?
I think the same way that we think for adults, so with even more care, just to make sure that we are doing what's best for them. If it's safe for the pediatric population and has been used in the pediatric population, I would say just do it. But again, I would not personally prescribe because I don't have the evidence for that. And that's the same for CoQ10. There really like a host of supplements that have been used historically for decades now for different neuromuscular conditions, including CMT. And as far as I know, have not shown to really change the progression or behavior of the disease in a populational manner. So that's the reason I don't prescribe, but we never know on a personal level how this would fare. And if it's a safe intervention, then yeah, why not?
Have you heard of any research or studies looking into stopping the progression of damage of the optic nerve for people with 2A? There is plenty of research, preclinical research at least, that originate from Robert Balo's group. But I don't know. And they did actually have a small molecule actually.
So yesterday they were showing. So it's one thing that's being used or being looked at in the preclinical or animal studies. So There is research going on, and it's well recognized to be something associated with MFN2. And it's something that it's definitely going to be incorporated in clinical trials because it's a very important endpoint.
Then the others are comments. Michael, for any patients that travel far to see you in the Center of Excellence, have you tried doing PT or OT locally with a therapist who has only one CMT patient versus PT in your institution who sees many CMT patients? Do you have any anecdotes about that give you an opinion on whether it matters to have a PT/OT who sees more CMT patients? I realize problems with strength and balance and coordination may be a commonality between different disorders.
Yeah, no, so for sure, and we can't expect that every doctor, therapist, social worker will have huge experience with CMT. So I think that the importance of going to a center of excellence is to kind of calibrate your needs and understand what are the best ways to move forward, and also to get information, because what we do is we try to always send reports and also material that patients can use locally to educate their providers. So what I tell my patients is when you're looking for a physical therapist, the first question you should ask is, do you know what CMT is, or do you have a patient with CMT? If the answer is no, don't just leave, because that, again, it's a very tall order. So the next question is, do you see patients with neuromuscular diseases or peripheral neuropathies? Because again, as you pointed out, the problems are very similar from a functional perspective, and that's what matters for the physical therapist. If they still say no, the last question you should ask is, do they see neurological patients? If they do, again, most of the problems will be similar: balance, sensory impairments, weakness. If they say no to neurology, then you should leave. Because if they have more of a sports medicine or orthopedic approach, the way they're going to approach therapy will be very different and counterproductive to most CMT patients, because they are with a mindset of, I want this patient to go back to normal function, and I'm going to do whatever it takes for the patient to reach that. So they tend to overdo it. And that can be, again, as we talked about before, it can be very detrimental. So getting people that at least understand neurology, ideally neuromuscular neuropathy, and in the perfect scenario, CMT, but that may be very difficult to find. I think that's kind of what you have to look for.
And then Richard comments, what is your feeling about zero balancing and dry needling with OT and PT in relationship with CMT?
I don't know.
I don't know. Yeah.
I don't know what zero balancing
Yeah,
is. Dry needling, I heard like patients doing some of that, and feeling that helps, but I'm not the right person to answer that question, just because I don't have enough experience seeing a lot of patients doing this to be knowledgeable on my answer. And yeah, cycle and swimming, that's all great exercises for CMT.
Yes, I would vouch for that as well. Then if that's the last question, we still have to grab a lunch for ourselves before the next session begins. And I'm very thankful that Mario is here, because with his clinical background, I would have sent you on a different path, most likely. I'm joking.
But a clinician and a patient scientist, so I think that was really a good pair. Thank you so much for being connected. Thank you for attending the conference, and hope to see you next year.